how long we stay. So with that, I also want to thank One Health Commission. So we're all being webcast right now, and this is going to be recorded and posted on One Health Academy's website. The One Health Commission facilitates that with their GoToWebinar account. So we really want to thank them for doing that, and they're the ones who really spearheaded the One Health Day effort that's now in its second year that happened last week. So it's a great effort. So with that, I'll introduce our speaker, Dr. Gavin Macgregor-Skinner. And so he works currently, as you might have read in his bio, at Apt Associates as a Senior Global Health Security Advisor. In this role, he works with colleagues at Apt to address such questions as how does the government strengthen and sustain its core public health capacities, what counts as a global health security concern, and in the context of governance of global health, how to detail and translate lessons learned from other programs. He has his MPH from Hopkins, his master's in science from Royal Veterinary College, and went to Queensland for veterinary school. So he's very qualified. So with that, without further ado, I'll turn it over to Gavin. Thanks.
Good evening, everyone. It's lovely to be here. It's good to see some old friends and also some new friends. And then I want to say what a great job Will has done. I remember the first meeting we had back in 2006, and the things that we had gone through those early years with Tom McGinn and Dave Franz and many others that were here, and how wonderful these evenings were. And I was just coming down with my wife in the car going, how many years has it been to the yacht club? And I didn't know where the new yacht club was, and I had to ring Will and say, where are we? Where are we going? But what I wanted to outline today, and I think there's been a significant paradigm shift in the way we do what we do. We've got so many frameworks. I'm going to talk today about, we all believe in One Health. We've talked about it, we've promoted it, we've advocated for it. We've got the global health security and how big or how small we want to take that definition. But how do we make things actually happen? So I'm going to give you a real plethora of my personal experiences, and I'm going to relate them back to what made them work. When those disasters happened at a local level, what actually had to be done to make the decisions to get the resources in the right place? We've got a problem, and we've always had this problem. We still have a problem imagining. This is Japan, March 2011. Who would have thought that Japan would have looked like that after we had the earthquake that led to the tsunami? And then what happened after that? Well, we had a food security problem. We had over 100,000 people were displaced. We had water, a water problem. We had 4 politicians resign. Didn't predict that, didn't see that coming. And then again, there was other cascades of events that occurred. So we still had this problem imagining. With the World Health Organization, we have public health emergencies of international concern, and really since the International Health Regulations were revised in 2005 and enacted in 2007, we've had 4 of those. April 2009, we had H1N1 pandemic. May 2014, we had the polio resurgence. August 2014, we had Ebola. And then February 2016, it wasn't Zika, it was the clusters of microcephaly and Guillain-Barré syndrome in northeast Brazil. I also wanted to put some emphasis. I had a number of trips to West Africa for Ebola with teams that we went over to set up hospitals, to manage staff. What you don't see in this picture here is a number of things. You don't see the family and the community standing over to the right. You don't see them crying. You don't hear them crying. You don't hear the noise. You don't see the little girl who's been led off by someone in a yellow suit. Why did we go from white to yellow suits? Because in some communities they said, we don't like the white suits, it represents death. So then we had to ring up DuPont and 3M and go, hey, have you got the yellow suits? Yeah, but they cost you more money. And we had to get yellow suits. And again, she can't recognize me when I'm dressed like that or any of my colleagues. So what are we dealing with every day? We're dealing with fear. And what did she have? She had fever. And where's she going? To the Ebola hospital. When we talk about One Health, when we talk about global health security, I use the health security definition from 2003. And I use that definition because it came out in the document from the UN Commission on Health Security, which said to protect the vital core of all human lives in ways that enhance human freedoms and human fulfillment. Then it says it means creating political, social, environmental, economic, military, cultural systems that together give the people the building blocks of survival, livelihood, and dignity. when we have to coordinate that, when we have to operationalize that, I find that emergency operations centres and the emergency management staff that I work with that come to me and say, hey, Gavin, what do you need? Actually facilitate meeting that health security definition. We've often been skewed in our definitions. Often we thought that One Health was protecting the next big pandemic, the next big disease outbreak. Global health security, which has been around really since the Constitution from the World Health Organization in 1946, it talks about health security. And then we've skewed it going, maybe it is preventing the next pandemic. What's our motivation to do that? Well, it's not that the disease is spread. It's not that we're not prepared, at least 70% of the countries aren't prepared. It's the money. It's the economic impact. It's the fact that SARS cost us $40 billion. It's the fact that Ebola cost us over $30 billion. When I was in northeast England, when I worked with Sam Mansley for the foot and mouth disease in 2001, why were we trying to stop it? Because of the economical costs. Not just the over 10 million animals that we had to kill, but the fact that all the factories were closed down because we were blocking roads. We were obstructing people getting to their normal job, and it was costing the community millions and millions of dollars. Again, there's lots of frameworks. There's lots of ways to explain and define what we do in One Health or global health security. And I hope you've all had a look at the Lancet, May 2015. Because this actual framework that David Heyman, who's now left WHO and has gone over to Chatham House and started what's called the Global Health Security area at Chatham House, actually came up with a framework like this, which is more holistic, more comprehensive, more looking at all hazards, and talks about the team and talks about the need to recognise the scope with all the other areas that we should be focusing on through our One Health lens and also our global health security lens. We are so lucky right now. We have so many frameworks to work with. I could put up another 16 frameworks. I haven't put up antimicrobial resistance framework. I haven't put up the pandemic global framework. There's so many frameworks I haven't put up. But we all should be aware of the UN Commission on Human Security, the International Health Regulations and how to operationalise that. OIE has their performance of veterinary services. The Sendai framework for disaster risk reduction. Who's read that one? That's a really good framework. And the challenge we have when we talk about risk reduction, disaster risk reduction, it's an all hazards approach except for who's not at the table? Health. Because health says, no, we have the International Health Regulations, we don't go to those meetings. Well, now we're seeing when we start talking about Sendai, and I was just listening to a meeting today in Jordan, all about Sendai. Who was at the table at last? The agricultural people, the health people. They're starting to join in and talk about what a wonderful framework this is and how we can make this happen. We have the SDGs, and then of course we've got the Global Health Security Agenda. I wanted to start with some examples. Let's go back to Zika. This is what we're really good at. When microcephaly and Guillain-Barré syndrome was sort of announced as the next public health emergency of international concern, what's the first thing that WHO did? They produced a map like this, and they coloured in Brazil because they reported their system worked, and they coloured in the US, and they didn't forget about Alaska because it's really important that we colour in these countries, and then they coloured in other countries throughout the whole 14,000 islands of the archipelago of Indonesia. We can do much better than that because what we've been doing, even just as recently as last year, as soon as we get a case, as soon as we get a diagnosis, instead of rewarding, incentivising that system, what do we go and do? We colour in Brazil. What did the Texas governor say? Don't you colour in my state. That's what he said when they got their first travellers that had returned back from the Caribbean with Zika. So what we do, so what does CDC do? So when they get the laboratory confirmed cases, this is a snapshot from the 4th of August 2016, we had 1,819 people that had travelled. We had actually 6 cases in the US where we had local transmissions. So what did we do? We coloured in text. Exactly as the governor said, don't you colour in Texas? I can tell you exactly the street name. I can tell you the neighbourhood where the cases are, but don't you dare colour in Texas. And then we coloured in all the other states. What does this do? How helpful is this? It's not very. It really isn't. And then what we did down in Florida, What CDC and the US government did down in Florida was, hang on, the zip code is 33127. And then we did a red rectangle in Miami-Dade and Windward counties and said, hey, don't you go from 6th Street Avenue over to 28th, because then you're in the zone. What does that mean? All those businesses, those restaurants, all those other businesses that suffered. If you live there, how do you interpret this? And the first maps that came out was a red rectangle like this. The next ones came out, and CDC someone had got their pencils out and they coloured in the red rectangles. And we published this on the website, on the public website, in September 7th, 2016, going, these are the danger zones. Don't go into the red zone. What does that do? And then the media, Fox News and CNN, they're really smart because they said, if CDC is going to publish this, we're going to go onto Google Earth and put the satellite imagery on there. And this is from Fox News. And Fox News says, active transmissions of Zika occurring, CDC travel advisory, don't go into the red zone. That was the message. Then I went on TV and I was asked, why is everyone so scared about Zika? Why are we dealing now not with a public health emergency, not with a public health issue? Why are we dealing with fear? Well, I think we know why everyone was so afraid. Because we didn't get the right messages out. We didn't mobilize the community. We weren't responsible. I'm going to start with 4 themes tonight. The first one is going to be... Sorry. You all right?
Yep.
The first one is going to be helping themselves, the people's initial response. And I want you to focus on where do disasters occur? They occur locally. Emergencies occur locally. And we need to be able to respond locally to ensure that they don't become a state crisis, a national crisis, and then an international emergency. So your advice will have to sound certain when the facts and science are not. So if I said you stop Ebola, because this is what happened, what would you do? That's what we did. This is what WHO, CDC, and the other governments did. They painted signs. They handed out flyers. Stop Ebola. What are we telling the community to do? I haven't got a clue. I've got photos I won't show tonight when I went to Miami to talk about Zika, and all the taxis had stop Zika. And I'm going, what are you telling the people to do? We know it's a problem. We didn't tell them to report people that had fever. We didn't tell them to stay away from the vomiting and the diarrhea. Anyone seen an Ebola patient? Bill, I've probably seen over 1,000 Ebola patients. The vomiting and the diarrhea will blow your mind. It is more the veterinarians, who's ever seen a dog with parvovirus? Times that by 1,000. That's an Ebola patient. It's worse than parvovirus. I gag and I reflux when I see parvovirus. Ebola was something else. It was so much diarrhea. And suddenly we're telling the community, stop Ebola. We didn't give them anything tangible. We didn't give them anything that they could act on. Then we got caught up in the science. The doctor dies of Ebola after testing negative. How could that happen? Well, it did. Because a lot of things can happen from the time we take the sample to the time we package it, the time we ship it, the time we get it to the laboratory and we process it, the time we put it in the real-time PCR to get a result. A lot can happen. And it's going through the science of saying, well, things do happen. The tests we use aren't 100%. They might be 90 or 95%. And we weren't prepared for this. And then in the absence of advice, your community will react. We got our first Ebola patient in Nigeria on a Wednesday. It was 1 o'clock in the afternoon. The team was there. The team had done a great job. The nurses were ready. The hospital was ready. The patient arrived. That night, I went on to Nigerian TV at 7:30, reported everything's fine. You know, and this is really interesting because when we arrived, we were called the colonials. Oh, the colonials have come to Nigeria to help. So I was introduced as a colonial. Even though I've got a southern accent, that's what I was called. Sat there and said, the Nigerians have done a wonderful job. The nurses, the physicians, the public health, the governor has done a fantastic job. What happened that night? We got attacked. The hospital got attacked. It may have been up to 3,000 people. We don't know. Where do you go when you get attacked in an Ebola hospital? You put your personal protective equipment on and you get in with the patient because they're not coming in there. The people didn't destroy the hospital. They didn't hurt anyone. They didn't break anything. They spray painted the whole hospital. Why? It's their community hospital. What did we not do? We didn't engage the community. What was the solution? Some German lawyers turned up and said, hey, you need to pay the whole community $1 million each. Well, that's not going to happen. So instead, 2 elders from the community were now put on the hospital executive board the next day, when the next patient actually arrived. Nothing ever happened after that. We didn't engage the community. We didn't put them on into the right meetings. I'm going to flip to Bangladesh. In Bangladesh, in 1991, 143,000 people died when a cyclone or hurricane actually hit. And this is an area of Bangladesh that gets hit every year by a hurricane, or as they call them, cyclones. In 2007, from 1991 to 2007, the Bangladesh government had created what's called a cyclone preparedness program. They had 40,000 people from the Red Crescent Society with megaphones. They had built hurricane or cyclone structures, and the plan was to move over 2 million people using 40,000 people with these megaphones. So in 2007, they got hit with a much stronger storm, and 3,000 people died. That mobilization of over 2 million people was through low technology of using the megaphones. But what happened next? There was a cholera outbreak. And when you move people, what do they take with them? They're animals. And when we read the plan doesn't include the cows, the sheep, the horses, the goats. And so what you don't see in this photo, here are the people here with cholera. On the other side of that green separation there, the green curtain, is all the animals. Suddenly, the hospital director is managing patients with cholera, and he's got lots of animals. That's the One Health approach that you'll never see written in any plan, and it happens every year. And it doesn't just happen in Bangladesh, it happens in many other countries. In 2004, I worked for CDC, and I was in the US Embassy when the truck bomb went off in front of the Australian Embassy, which is just down the road. Now, if you work in if you're in the US Embassy and a big bomb goes off in Jakarta, what do you start thinking? We're next. We thought we were next. They had attacked the Australian Embassy. For sure they were going to attack the US Embassy. What happens in a situation then when a bomb like this goes off? We all went into what was called the grey zone. None of us. We all rushed to the window. First smart thing to do. Oh, look, there's a bomb. Looking out the window. Next, we stood around going, what do we do? What do we do? And it was Herbie Smith, and he had been an emergency manager and he'd been trained for disasters and then done all this stuff. He was the only person in the room that went to the shelf, grabbed the folder, ripped out the checklists from the annexes and went, we've got to do this, this, and this. Here's the drill. None of us had been trained. None of us had been prepared to handle a catastrophic event like this, which really shocked all of us. Herbie ripped those out, handed them all to us, said, follow the checklist. And that was the only thing that brought us back to, out of what do we do? I want to move on to talk about the value of traditional wisdom and modern awareness, because often in our plans, in our strategies, even in our training, we don't think about this. In 2004, we had an earthquake, then a tsunami that hit Banda Aceh. When I was deployed to Banda Aceh, one thing that I'll never forget is the number of shoes I saw. In this photo here, all the buildings have gone, but what was on the ground? Where was the couches? Where was the refrigerators? Where were the TV sets? They were gone. It was the shoes, and the shoes everywhere. And in Banda Aceh, you know, this particular earthquake and this particular earthquake that led to a tsunami, we had over 280,000 people died in 14 countries. There was no tsunami warning system in 2004. Here's an area, Banda Aceh is at the top there. So I want to talk about Simeulue Island, because one of the first jobs I had when I was deployed there was to hop on a boat and go to Simeulue Island. Why? Because the US government through USAID had 2,000 jerry cans that we had to load on a fishing trawler and take to Simaloo Island. I then got a phone call from the embassy going, have you checked the brown bag? No. What's in the brown bag? 2,000 stickers to go on the 2,000 jerry cans from the American people. And I said, no, I'm about to hop on a fishing trawler. I'm not putting the stickers on. I said, no, Gavin, you don't get it. You work for the US government. You're going to put the stickers on. So my team stayed up all night putting stickers on the 2,000 jerry cans that we were going to distribute when we got to Simaloo Island. But Simaloo Island was an amazing place. In 1907, Simaloo Island was hit by an earthquake and a tsunami. Up here in Banda Aceh, 83,000 people died. How many died on Simaloo Island? 7. 83,000 at the top, 7 on that island. What they did, when the water went out, and they showed me how, the water went out over a mile. The water, they said, see that island there? It went beyond that. It went out at a mile. In Banda Aceh, they all ran out when the water went out to pick up the fish, and the silt was gone. In Simaloo, when the water went out, they ran up the hill with their animals. With their animals. That's folklore, that's storytelling, and that's so powerful. It's beyond whatever we do when we start to prepare and train for a catastrophe like this. We saw the same thing in Thailand, and again, all these areas in 2004 had no signs like this. Now when you go to Thailand, in case of earthquake, go to high ground or run inland. But the other thing amazing about Thailand is that for years they've had community volunteers, all hazards, community volunteers. There's 750,000 of them. And the day the earthquake happened, the day the tsunami happened, all 750,000 activated themselves and took on leadership roles throughout the community. And this is well documented. And how they then promoted resilience, organised the community to go into what was then survival mode, what they needed to do. And again, we've got lessons from Thailand. We've seen lessons from Indonesia, things that we should be talking, this is 13 years ago, that we should be talking about all the time of how to facilitate and do more storytelling. But now if we look at modern technology, we're going back now to Ebola. We used high resolution satellite imagery because there are no borders in an emergency. There are no borders in an outbreak of disease. They don't exist in many countries that are contiguous. And one of the things that we used in 2014 for Ebola was these high definition satellite images to identify what? People are very habitual. People go across in the same boat every day to get to work, to get to the market, to see friends. This can all be picked up by satellite imagery. So suddenly, not just having the physicians and the nurses leading the Ebola outbreak, we actually had digital remote sensing people who had never talked to going, I think that we can help. And they showed us these images and said, this is where you need to go intercept. This is where your risk is. What other things that we did, not just for Ebola, but also yellow fever and other disease outbreaks now, is using machine algorithms by looking at the satellite imagery that we have and using machine algorithms to identify what houses have movement, have the soil disturbed around them, so they're lived in, compared to what buildings don't look like there's anyone living there. Because often when we look at a village, we go, oh, there's 50 houses, there must be 200, 300 people. That wasn't the case. So we could use satellite imagery now and a machine algorithm to actually identify what do we expect the population to be in that village? What do we expect to be the vulnerable population that we need to intervene with? How many? We can start allocating resources. How many of these do we need when we go there? Again, the importance of local capacity in responding to an emergency. Now, One Health projects, our global health security projects, we're focused at the national level. Sometimes we get down to the state or the province level, but rarely do we penetrate the local capacity, the local level. In 2005, there was an earthquake in Pakistan. In 2010, there was a flood. I'm going to focus in on Korora Hospital. This is an area where USAID responded to in 2005 and 2010. And the hospital director said they had designed the structure to resist earthquakes, but God sent the floods. What happened in 2005? The hospital was destroyed. This is about a 150 to a 200 bed hospital. It's the only hospital in the area that was rebuilt using US government money. Where was it built? On the floodplain. If we had engaged the local people and said, hey, why is that hospital built up there and not down here? Well, that's because we had a flood 50 years ago. Haven't had one since, but we had a big flood then. That's why we built the hospital up on the hill. But instead, we built the hospital down near the river on the floodplain. So when the floods came in 2010, what did it do? Wiped out the hospital. How often do we go into these situations, these emergency situations, and we don't rely on the locals? We don't engage them in the appropriate way to use the information that they have. The other thing that Pakistan floods did for me, and it really changed the way that I work now, is it created visualization. So 7 years ago, for the very first time, we started to do more data visualization. The patient medical records. In the area that I was working on in Pakistan, we had 36,000 TB patients that we'd lost. That were at one stage on a database, the next day after the floods they were gone. No one could track them down. The open medical records system was coming out of Macgregor University in Uganda. And the job that we did was link up Macgregor University in Uganda with Karachi Hospital, Indus Hospital in Karachi, and others to say, can you translate? Can you share your experiences? Can you share the code? Can you share the database? Can you share the program? Because there's nothing in Pakistan and they need to go from 0 to 100 really quickly. And that's what happened. By making those connections, very little cost, a program that was working very well in Uganda was taken into Pakistan. Again, with the hospitals, there was the Padang earthquake in 2009, and I just want to, it was a 7.6 on the Richter scale in West Sumatra Island in Indonesia. More than 1,000 buildings were destroyed, 10 hospitals, 53 community health centres, 137 supporting community health centres, 15 village clinics, and 2 pharmaceutical warehouses were completely destroyed. Out of the 10 hospitals, what happened next? There was only one hospital, the Yossudasu Catholic Hospital, that had done any sort of drills, had done any sort of exercises. After 10 hospitals had been destroyed, 9 never got up running again. The one hospital that did was the Yossudasu Catholic Hospital because they'd been trained in emergency management. They had the necessary training to say we could set up this hospital outside of the building and actually treat patients. And it's a real lesson learned that for a very small investment in 1 of 10 hospitals, that we saw the resiliency, the recovery of that hospital being able to set up and accept patients within a 24-hour period after the earthquake occurred. Again, on community mobilisation, one of my trips to Indonesia when I was at USAID for H5N1 for bird flu was that this is an official UN WHO convoy. We had mapped out the areas. We had a huge area in West Java, actually, of an area we had no information from. So we decided, let's jump in our official convoy and we'll drive there. This gentleman here jumped out of nowhere and stopped us. We can laugh about it now. He stopped an official UN convoy. And he stopped it because he had a backpack on his back. And we knew no one had been out here to train. We said, what are you doing? I saw this on TV. What do you mean you saw it? I saw this on TV that every vehicle that comes off this road is a risk for our livelihoods and I need to spray it. And he had disinfectant, he had Virkon. And he was mixing it appropriately. We tested the pH of it. And he sprayed our cars. And we all sat there going, you saw this on TV? What are we not doing right with the amount of outbreaks that we were having? And he just said, yep, that's what I'm doing. And he had made himself the official gatekeeper for this whole community. I spent so much of my time in 2014 earning the money that my team and myself earned on doing what? On teaching people to put on the PPE and take off the PPE. Something that we should never have done. Teaching people how to put on the gloves and then use the debeaking method to take the gloves off safely. I remember I went to one hospital and the nurse there had been nursing for 28 years. And she virtually said, Gavin, you, not in this language, but she said, Gavin, you can't tell me how to take off gloves. I take off 40 pairs of gloves today. I said, right, I'm going to cover your gloves in chocolate sauce, show me how you take them off. Splat! Goes the chocolate sauce. Now we need to address that if that's Ebola, you've created a huge risk. I spent so much of my time teaching people, donning and doffing. Fatu Kukula became famous because she was on CNN, she was on Morning Express, she was on BBC. What had she done? She treated 24 patients using plastic bags. She took primary precautions, universal precautions, and she took them back to first principles, and she put plastic bags on it, and she took them off properly and disposed of them properly, and she treated 24. When you see an image like that and you start seeing this lady demonstrating, what happens in a country like Sierra Leone and Liberia? It goes viral. Suddenly we had bag ladies all over the country because in the hospital that I was at, we were getting 60 patients a day in a 210-bed hospital and we were turning them all away. We couldn't accept anymore. These ladies were saving lives. Not captured in any standard operating procedure, not captured in any manual, but that's what they did. When I came back to the US, and Tom Frieden, who was the CDC director, said every hospital in the US is ready to take an Ebola patient and treat them. What did every hospital director say? No, we're not. What did all the insurance companies say? No, they're not. What did Wolf Blitzer talk about, Seema Yasmin and myself? Where are the CDC guidelines? Because the hospitals, insurance companies are saying, we're waiting for the CDC guidelines. The 30-page document came out. It took a PhD to read and understand it, and then you had to try to operationalize it. So we made more money. We took the CDC guidelines and you need a couple of checklists. I can make some checklists for you. And then we got to version 17 of the CDC guidelines. What did we do then? We stopped reading them. The point is that the basic training that our nurses had, our physicians had, our auxiliary staff have, was good enough to stop Ebola. And we created so much fear and anxiety that we had to wait for a higher authority or a government agency to tell us what to do. Because we forgot, just like when we dealt with foot and mouth disease in 2001, just like when we deal with any Ebola virus or any other virus, bleach kills it and soap and water kills it. And that message in the US didn't come out. The message came out in West Africa loud and clear. And it came out the wrong way. Because when I was coming out of the Ebola hospital after seeing the Ebola patients and we'd decontaminate and get sprayed, what were they saying to me? Gavin, you don't smell strong enough. We're going to have to spray you again. No. That's enough. My skin peeled for weeks. The smell I had of bleach in my nose, in my throat, didn't go away because we didn't test it by pH, we tested it by smell. If you didn't smell strong enough, these guys are going to spray you again. I want to talk a little bit about grassroots preparedness, and this is where we need to change the paradigm. We need to ensure that those guidelines we get from CDC or from USDA or from HHS or from DOD or anyone else gets down to the local level. How do we operationalize those down to the local level? 2007, I arrived at the airport in Jakarta. I was working for USAID. Peter Roda, veterinarian at FAO, picked me up, and I said to Peter, and I've known Peter for a long, long time, what's it like? I can't repeat what Peter actually said, but I think what this map shows it, we had such a high viral load that it was we had a real problem. Jeff Mariner, also from FAO, was there as well, and we looked at this map and went, oh my gosh, H5N1's been laboratory confirmed in 30 of 33 provinces, 216 of 444 districts. That's a lot of virus. In a country that's not contiguous, it's separated by water, that's a lot of virus. Where do we start? What do we do? Well, even today, what's the tool that we use in every emergency, every outbreak, every disaster? The phone. What don't we have now? We don't have databases that can accept photos. I brought 850 photos back from Ebola on my first trip, and I went to State Department to show them, and, oh, you can't bring your phone in. But I've got 850 photos you need to see. Maybe we could meet in Starbucks. I said, no, these are highly classified photos. You can't go. But we did. We couldn't share them. These are dumb phones. Dumb phones worked back in 2007 because DuPont and Dow, who were making lots of money with their disinfectants, especially in Indonesia, we were going around testing the pH, and we found that no one was mixing it properly. So we went back to the companies and said, we need calculators. We need calculators for these disinfectants here based on the size of the bucket and the amount of water put in there to tell people this is how many scoops you put in. Because we had to decrease the viral load, and the way we would do that is through the disinfectants that we're using, if they were used properly. And they rolled this out to 27,000 phones. We haven't done a lot of this since, and we need to do more of it. There's so much we can do with our cell phones nowadays. The other point that I wanted to make was the mobilization. Indonesia had an emergency management, a community emergency management program. They responded to earthquakes, they responded to tsunamis, they responded to volcanoes, but they never responded to an infectious disease. 80 master trainers were trained by Peter Roeder and Jeff Mariner, who in turn trained 1,753 volunteer sub-district avian influenza coordinators that then went on to train 25,210 village points of contact, village leaders, in 124 districts. And then what did they ask the US government they wanted? A sense of identity. They wanted orange t-shirts. So I went back to the embassy and said, we've just trained, what was it? Really 26,000, 28,000 people. I need to buy 28,000 shirts. And the chief of staff said, no, we don't do that. I said, no, we really need to give these people an identity. We need to buy orange shirts. That's what they want. We got through that. The big mistake we made is that we all put it in English. So this is what the US government did. We put this in English, Muhammadiyah, disaster teams for avian influenza. We didn't put it in Bahasa Indonesia. We didn't put it in the local language. And we gave out all these t-shirts, which gave them a sense of identity, which gave them a sense of credibility, which then helped us decrease the viral load. One thing that we used a lot of, anyone done participatory rural appraisals back in the 80s, back in the 90s, where we got the community to actually tell a story? Participatory epidemiology or participatory risk mapping was so important to decrease that viral load of bird flu in Indonesia. And here's a husband and wife in a village telling us what they knew of how they believed maybe the virus came in and where it spread. And they then
equivalent to a focus group.
Exactly, Bill. And they then produced diagrams like this on big pieces of paper. And this one had spread from the local poultry farm, the commercial poultry farm, where there were workers who'd come down without changing their boots, without changing their clothes, into the village. And again, this village is highly populated, and they actually showed how it spread. And then it went over, it then spread to the next valley. Well, it didn't actually, when we went to the next valley, it didn't actually spread. It was a complete new transmission of the disease, again, from the same commercial poultry farm. That's all captured on that story there from the community. What do we do with it now? Well, I've still got some of these at home. We didn't have a system of how we digitalize them. We didn't have a system of how we share them with the government, but we had so much intelligence, information to act on. And then it worked in the cities. And this was an outbreak in the city where the government, in a knee-jerk reaction, said, oh, it must be the wet market. It must be the market where they're selling the birds. And we took all these environmental swaps, and how much bird flu did we find? Nothing. Absolutely. We just closed down the whole bird market, everything else that was attached to that market. All the livelihoods have stopped. And what we found through our participatory epidemiology, our participatory risk mapping, these people up here were owed money, and they weren't paid money, they were paid birds. And this became a real currency. People were trading birds to pay off debts because they knew they were sick and they're going to spread disease. And that's where the disease started, in those 3 houses there. And we knew they received birds from another location which had a large outbreak. And again, by capturing intelligence information like that, we could then go back to the government and go, you've got to open up the wet market. The poultry market can open up right now because that was not the risk factor, and already the lab has shown there's no virus circulating. We go back to Ebola in Monrovia, Liberia. On the left, this is the map we had. This is what we had to plan our case detection, to plan the risk mitigation measures that we're going to take. But in a 2-week period, working with Esri, Google Earth, OpenStreetMap, TopNode, Ushahidi, GIS Core, Telestory, Digital Mapping, look what they produce. If you get the right people at the table with the right tools, they can go from like this to like this, and it was a 10-day period. How many countries or how many locations have I been where we don't have good maps like this? Where's my? I put my phone. Everyone got a phone? Do you know what? Do you know your phone works as a GPS when it's turned off, when it has no connection? Do you know how many teams I've sent out going, well, I can't actually tell you where it is, but we've got 10 people that are sick, and we've got 12 cows that are down, and I'm going, where are you? Can't tell you. Look at your phone, because there's a GPS chipset in that phone, and whether you've got connection or not, that GPS chipset will work all around the world and will tell you exactly where you are. It's something we have to trade. I teach a pre-deployment course up at Harvard. We had 76 physicians. We threw them out into the forest in Worcestershire just recently. We give them little, we give them those straws, those filter straws, and no water, so that they have to drink out of ponds and creeks and all sorts of stuff for 3 days. And they went, and we gave them points. Get to this next point. We went, how do we get there? You have a GPS chipset in your phone. Use it. None of them had used it before. And they couldn't navigate with a compass. And this was part of their pre-deployment training. Cooperation among sectors. Whenever you look at an after-action review of a disaster, what are the things that come out every time? Coordination, communication, and collaboration. All the C words. And I think, Bill, you'll agree, and we went to, I think all of us got to a stage back when we did bird flu. No more C words. Stop the C words. We don't want to hear that anymore. How important it is for the cooperation, the coordination, the communication, and the stuff that we have to do.
There's a saying, everyone wants coordination, but no one wants to be coordinated.
And you're absolutely right, Bill. And this is where my experience has shown, say, in emergency management or emergency operations centers, they're very non-threatening. They're very neutral. You know, we get an infectious disease outbreak, and who do we make as the incident commander? A physician. We get a hurricane or a cyclone. Who do we make as the incident commander? Not a meteorologist. We put an emergency management person in there. And within health, both animal and human health, we don't use our emergency management people enough. I first came across this in 1996. I was in the British military. I was actually in the Vet Corps, the Royal Army Vet Corps. I was attached to one UK armoured division in Germany, having a great time. I was fly fishing. I was playing golf. All the things you do when you're in the military. They even told me I had to go and learn how to sail. Oh, really? So I went and learned how to sail. It was hard. Then I got deployed to Bosnia. No one told me I was going to Bosnia. And what I was told to do by General MacDonald at that stage was show the benefits of peace. Had no idea what he was talking about. So what we did, we started veterinary programs throughout the whole country. I didn't know how hard that was going to be. Our biggest success story was 21 trucks came in from Germany with pregnant heifers. And I actually have a satellite photo which showed the heifers all coming in from Germany into Bosnia-Herzegovina. I was based in Banja Luka. But here's all the lists of all the veterinary agricultural projects that we set up in 1996 after the Dayton Peace Accord was signed to show the benefits of peace. I learned that as a veterinarian that I thought I could do everything, I couldn't do anything. I needed so much help from so many other sectors that I haven't even met. That taught me without engagement of all these different professionals and sectors, I can't make anything happen. And over that sort of that period of 1996, we actually showed the benefits of peace. We got people out of their displacement camps, back into their villages, back into their towns, back into their farming. In Indonesia, there was an earthquake in May 2006 in Yogyakarta. Again, emergency managers had the government organised. The man here is in his government uniform, driving around on the back, getting the message out about the earthquake. In 2007 and 2008, we went, oh, could we use the framework that you developed for emergency management for earthquakes for bird flu? Yeah, all we have to do is change the flip chart there. So we made a new flip chart. These are the risk factors for bird flu with the same people on the same motorbikes. There's over 200 of these people traveling now around the provinces of Indonesia, spreading the stories of how to decrease risk, how to protect your livelihoods. Never before had they talked about an infectious disease, never had an experience of an infectious disease, but they loved it because they've been trained, and we hadn't. This is a part of the community we'd never engaged with before. Who uses Twitter? You want to use Twitter? I haven't got a clue what Twitter's for, but I'm on it. I first saw that Twitter could be useful was in 2010. We had the Haitian earthquake, and I don't know whether you know this, but in Haiti, it was from January the 12th to January the 14th, there was 2.3 million tweets that either had Haiti or earthquake in them. So over a 4-day period. Of the 2.3 million tweets, 59% were retweets, 1 million were original. The American Red Cross had their 90999 number that you could tweet to $10. You could tweet $10 to help the people of Haiti. Now, in 2008, when Hurricane Ike hit, the American Red Cross said, yep, we're going to have people call the number 90999 or send a text message. How much money did they raise in 2008? $190,000 for Hurricane Ike. 2 years later, in 2010, with $10 on Twitter, sending that out, how much did they raise in 4 days? $8 million. That got my attention. Now we're talking. Now I know what we can do with Twitter. Now we can grab the community. Now we can make the masses do something that's really worthwhile. Anyone heard about the Marburg outbreak recently? This for me is revolutionary. The Ministry of Health, WHO Uganda, WHO in Geneva, all did what? WHO, Ministry of Health, working closely to contain the Marburg outbreak, prevent further spread. Incident management experts already at work. Not the physicians, not the nurses, not the doctors, the incident management, the emergency management people were being mobilised. The next one came out. What are they doing? WHO teams providing risk communication, case management, contact tracing, surveillance to tackle the Marburg outbreak. All came on Twitter. I hadn't seen this before. It went to millions of people. We didn't have to wait for an official report. We didn't have to wait for some politician to stand up. We didn't have to wait for the report to come out on a Friday. This was coming out in real time over the course of the 3 to 4 days when teams were being deployed. And it was amazing. And it was being pushed with information from the newspaper, but also with real photos. We could see this was the real deal. And again, we now saw that the UN, through WHO and the government, had started to use Twitter. Why? Not to create fear, but to create real information, correct information with credibility to tell not just the country, but also the international community what was being done. And we saw the same thing in Nigeria. We hear a lot about the Nigerian government and their plans for Ebola was based on polio and TB and HIV. No, they went further than that. There's a whole discussion we haven't had around this. They went further than that. And Dr. Parker, what he had developed very quickly was the toll-free number. Does anyone remember the toll-free number we had in the US for Ebola? Oh, that's right, we didn't have one. There wasn't one. But they had a toll-free number, 0800 Ebola Help, a website, an email, a Twitter, a Facebook, and they gave out the mobile phone numbers of the State Disease Surveillance Officer and the State Epidemiologist. What we had back here in the US? Not a lot. But they were so well organised. This brought both the private sector and the public sector together. When I came back after my first trip to Nigeria, set up Ebola hospitals and treat Ebola patients, I went down to Emory University Hospital to help train their staff. And I looked at their communication. And this is Emory University Hospital, Midtown. At the front door, don't take your gun. That's important. Don't smoke. That's important. And at the top, you probably can't read it, but it says, tell the staff if you've been to one of these 3 countries, Guinea, Liberia, Sierra Leone, or, and if you have a fever. And I sat there with the valet, and I sat there with the security guard, and I went, how many people read those? Well, I've been working here for 15 years, and not one person reads those. Why did hospital administration put these up? Because they look good. And then I went over to Tennessee, to the University of Tennessee Medical Center. And I walked in the front door and I went, wow, this is great. If you've traveled to one of these countries in the last 30 days and you're not feeling well, please let a hospital representative know immediately. How many staff work at this hospital? 5,000. What's a hospital representative look like? Any person with the name badge. And they've all been trained. No, they haven't. Then they said, because we're all really good at geography here in the US, they said, if you've been to Guinea, Liberia, see those little coloured-in countries there? Of course, that's Africa. Everyone knows what Africa looks like. MERS-CoV. This is so confusing. And these were all over the hospital. So what did we do? Well, across the road from here at the hospital is a faculty, a medical faculty. And I went across to the dean and said, we're going to have an exercise. Oh, Gavin, they take weeks, maybe months to organise it. No, we're going to have an exercise at 1:30 this afternoon. I need 30 med students. What are they going to do? They're going to pretend they've just come back from West Africa like I have, and they will have a fever. And then they're going to spread out through the hospital and find a hospital representative. Because we're going to test this plan. How long did the exercise last? About 10 minutes. There's absolute chaos through the hospital. Phones are going off. Who started this? Who's doing that? I'm testing your science. That's what you're paying me to do. It didn't work. Then I went through for Zika, and I went through, this is Atlanta Airport. Again, from the Department of Public Health down in Georgia. Zika virus, protect and prevent. Head into one of these countries. We're really good at geography, aren't we? What countries are they? Oh no. Just had a wonderful vacation. Can't really find it on a map, but gosh, it was good. Then it doesn't tell you what to do. It doesn't give you any actionable information. And these are all over the airport. And I met the director of the airport. And I met the staff from the Department of Public Health. And they said, how do you like our signs? I went, how are they working for you? How many patients have we captured? How much feedback have you had? These go up all over the place, and they're useless. They're worse than useless. So I want to go back to crisis risk management, because in our One Health approach, in our global health security approach, we're looking at a commitment to a process to make the best decision in a highly uncertain environment. And a quote from Theodore Roosevelt said that in any moment of decision, the best thing is to do the right thing, the next best thing is to do the wrong thing, and the worst thing is to do nothing at all. And that happens a lot because we have so many frameworks now. We have a plan to manage risk. We have the Joint External Evaluation Tool, which we can develop. We do through a process of self-assessment, external evaluation that leads to roadmaps. We have a plan for 11 action packages, 19 thematic areas, 55 milestones, 2,200 indicators. The Sendai framework is something very similar for all these countries that have signed up to Sendai every year are doing risk assessments. Some of them are doing more than one a year. And if you can't see that, Emergency Support Function 8. Anyone know what ESF 8 is?
No.
Yeah. So under our national response plan, we have ESF 8. And here it says the Department of Health and Human Services, they're the coordinator, they're the primary agency, but then there's all these other support agencies. How do we get them to work together? We have to have an exercise. We have to have a drill. We have to have a tabletop. We have to get them in a room in an emergency operations center, and we have to talk about the real world issues. Because I know from teaching this, I teach 3 courses at Penn State. When I teach this and I talk to my federal government students, they aren't aware that they need to be talking to HHS if they're working for Department of Energy or Department of Commerce or they're in the Department of Homeland Security. They aren't aware of any way that we've actually started to actually operationalize this and make it work. And we have. We do this a lot. And it's really important that we start to bring in so many stakeholders that we have to operationalize these through exercises. One thing I've noticed since we've started doing global health security, started doing Sendai, the meetings have got bigger. I recently went to a country where we had 116 companies in the meeting. I've never seen anything like it.
In Haiti, after the earthquake, just in the health cluster was more than 500 NGOs.
And that's really exciting.
And they couldn't even fit the representatives in the building that they had.
And I think that's really exciting. We had the same thing in the Caribbean when we took a regional approach for global health security in their One Health program. We had 76 organizations in the room. More people, but 76 organizations. And the nice thing now is we've taken these frameworks, Bill, and we've created checklists. exactly what Dr. Parker did for Ebola in Nigeria. When he had over 130 organizations there, he went, I need public service announcements. And this Bluebird Insurance Company stood up and said, who's Bluebird Insurance? We'll pay for every 50 minutes for a public service announcement on the radio and the TV. Never heard of Bluebird Insurance, don't care who they are, but if you're going to pay for them, go for it, this is great. And that's what they did. And then we saw the oil companies, and then we saw the other companies all come to the fore and be part of a huge needed response. So there's 4 things I want to leave you with. First, we need to practice community inclusion, and we need to do better than that. We're dealing with systems of systems, and the way we're doing that now is through dashboards. This is a dashboard from PEPFAR, and these dashboards are so important because they create situational awareness from any information source. So we can go right down to the hyper-local level, down to the community, as well as the official structured, but also unstructured information, and we can visualize it both on maps and in graphs and show what we need. Second, we need to develop models to determine risk parameters. This was published by WHO as we were having the outbreak in Ebola in West Africa. 14 other countries were doing risk assessments and needs assessments and capability assessments. And you can see here we had the country preparedness summary here of sort of 11 critical mission functions. We used a stoplight system. Red means they haven't done anything. Yellow means they've done something. Green means they're pretty capable. And then within that we put percentages. So if you're yellow with a percentage, it means that you've had your first meeting. That's all it meant. And you've started to put the plan together. And that's how low we took our indicators down to. And these were updated every day. And we did this for so many other countries as well, for so many other disease situations. Third, we need to optimize decision support. And this is so important. I wanted to give an example here, again, where we set up with a Cordia Global Health Foundation. I was working at the time for Elizabeth R. Griffin Research Foundation, and we networked with 12 universities, over 5,000 students, to start to deploy a resilience program for the whole community mobilization. And the way we did that was through face-to-face networking, coming up with content taken from CDC, WHO, looking at the different delivery platforms that we use here for our teaching, for both our online and our face-to-face courses, leveraging that, and then using faculty that are experienced in adult education. Fourth, we need to manage actions. And if there's one thing that Ebola taught me was that this was the evolution of dashboards. This was the evolution of portals. I think at one stage the US government had 23. I only used one. It was from the DoD, because that was the one that was always up to, I think, was up to date and had the best information. And again, the DoD one actually told us what actions were being taken right down at the local level once they had arrived. And so that was the one that I carried around on my iPad and my phone. And we're seeing now that these dashboards now are coming out for so many other vertical disease programs, both animal health, human health, but also environmental situations as well. And if you guys, if you're students and you're thinking about what you need to do, go and learn Tableau. Go and learn how to make these, because there's big money to be made if you can take lots of information and visualize it. And with the end goal there was enhanced response. And I want to emphasize that we still haven't set up a platform through our One Health programs, through our global health security programs to show what works, but also more importantly, show what doesn't work. And so that after we've gone into an outbreak of anthrax, or an outbreak of foot and mouth disease, or we've gone into another outbreak, those lessons aren't anywhere. We're still making the same mistakes. And one thing that General MacDonald, my commander for one UK Army did in 1996 when I went to Bolivia, said, Gavin, we don't have lessons learned. What we do is commonly made mistakes. And that's stayed with me ever since, because General Mac was right. And we haven't got a platform to share those commonly made mistakes. So I just want to finish up with, again, I see more emergency operations centers being the pivot point for so much of the work we do in One Health and global health security. I see them being as non-threatening. I see them being neutral. I see them as convening. I can tell you now from personal experience, the meetings I go to are huge now with so many stakeholders, so many actors, that we need to have strong organizational models. We need to have high functioning governance that allows for rapid decision making and deployment of resources. We need successful collaboration with other state and non-state actors, and then adequate financing. So many countries I go to have emergency management agencies here, with emergency operations centers here for earthquakes, volcanoes, tsunamis, and then they have a public health emergency operations center over here that's run 9 to 5, Monday to Friday. And they're not open on weekends, and they're not open after 5 o'clock. We've got to move away from that paradigm and put all our eggs into one basket under emergency management and ensure that we work with emergency managers, because they're the people that are going to come to all of us and say, what do you need? How can I help? So I just wanted to finish up, and going back to Indonesia, I just really think from the lessons we've learned in the experiences, the personal experiences that I've had, the transition now is for emergency operations centers to have broader mandates and new institutional models. And if we can make that happen, if we can get into a comprehensive exercise program, if we can go further than what JCO or the Joint Commission says, do 1 exercise a year, and we'll give you a tick in the box, if we can move away and create a culture of exercise, tabletops, functionals, drills, full scales, then it doesn't matter how many frameworks we have, how many plans we have, we're going to be better prepared. So I'd like to thank you all for coming. Again, this has just been wonderful. I think, you know, Will, you're doing just such an outstanding job keeping this going. I know back in 2006, I think I was the 2nd speaker. I think maybe Carl Taylor was the 1st, I'm not sure, but I think I was the 2nd.
I know Tom was really excited to have you come back this time to speak, so he says hi.
But what's been so fun about this group is that, you know, I haven't seen Tracy for years. I haven't seen Bill for a long time. You know, we haven't seen each other. John, it's been so long. But we know that when the emergency happens, we're all going to be together, and we know we can make it work. And that's what this group has really done for me. So thanks, everyone.